Bismillahirrahmanirrahim. I welcome all the participants. And first of all, I want to thanks our sponsors, Snipe from China, who have arranged this wonderful webinar. And I am thankful to all the members of Pakistan Society of Chemical Pathologists who have spared their time in the evening, which is their own time, for this webinar. The topic I have chosen for today's talk is role of acute phase reactant estimation in a patient of COVID-19. Why I have chosen this topic? What is the background of my talk? Uh, I have noted that in the current wave of, and also in the previous wave, uh, in patients who are already diagnosed as COVID-19 or who are symptomatic, and either admitted or being treated as OPD patients, uh, there a list of certain biomarkers are advised and monitored. These biomarkers include some acute phase reactants. They include some tests for hematological disturbances like D-dimers, then some enzymes, LDH, and some other tests. So there is a need to work on these biomarkers, and people are coming up. They are doing evaluating these markers in various studies these days. In fact, all the aspects of COVID-19 are being investigated by various researchers. So I've chosen out of these biomarkers the acute phase reactants, which are advised and monitored. But I felt a need to talk about it to enlighten our colleagues, not only clinical, not only laboratory colleagues, but also clinical colleagues about the uh, about their actual significance. So there's no conflict of interest. We will use some proprietary names, and this webinar is sponsored by a company, a firm, Snipe, and but we will be using no prejudice, and we will just want to keep the audience aware of the products. Specific learning outcomes. At the end of the session, participants will be able to describe various acute phase reactants, role of acute phase reactants in a patient of COVID-19, comparison of various APRs. These are my specific learning outcomes. First of all, I want to discuss some myths about COVID-19 lab tests. Since we are lab people, so we will discuss the myths about the lab tests. And as my students know that my talk is usually includes some questions, some MCQs and I invite participants to answer those questions. So if anybody can answer these questions by chat or something, they are most welcome. A medical researcher is validating, determining diagnostic accuracy of various biochemical markers used in patients of COVID-19. Which of the following tests should she use as reference standard, gold standard? First is CRISPR, second is gene sequencing, MARDITOF, quantitative RT-PCR, and RT-PCR. So what do you think? Okay, it is the gene sequencing. Uh, Please remember RT-PCR, which we are currently using, which is a qualitative PCR, is not gold standard for uh, COVID-19. So the first myth is that RT-PCR is a gold standard for COVID-19. It's not true. In reality, RT-PCR has only 50 to 70% sensitivity, depending on the specimen site. Some people say higher sensitivity from the nasal, some say higher from the pharyngeal, and most of people agree that sputum has got the highest sensitivity. Anyhow, is the sensitivity of gold standard should be nearly 95%, and it is far away from that. So truly speaking, only gene sequencing by next generation sequencing can be regarded as and gold standard. The studies, actual studies which validated these PCR, they use this gene sequencing. In Shanghai, China, they used this NGS gene sequencing for uh, they used it for in patients also. They they did wonderful job. There's a paper also that mm, they did it in all the PCR negative patients. In our setup, however, we may use RT-PCR and for research study because it is the most commonly used test. Second question is a 47 years old man is suffering from fever and sore throat. He has history of contact with a patient of COVID-19. His lab investigation result shows uh, HSCRP is normal, IL-6 is normal, is normal, ferritin is normal, and COVID antibodies are normal, and but PCR was not advised in this patient. So what should be the next action in this patient? Antibodies should be repeated after 4 weeks. APRs should be monitored on daily basis. D-dimers should be carried out. No test is required. COVID-19 is ruled out, or RT-PCR should be done. So, what do you think? Which is the best option? Yes, RT-PCR should be done. You cannot rule out COVID-19 just by these biomarkers or by antibodies, especially if they are carried out on the lateral flow assay. If they are done on the chemiluminescence, then that is different story, but not on the rapid test. So RT-PCR should have been done in this patient. So second myth is that acute phase reactants like HSCRP, like ferritin, like D-dimers, tests like D-dimers, they can be used for diagnosis of COVID-19. In reality, acute phase reactants should only be used for the monitoring of an already diagnosed patient of COVID. So they are markers for monitoring the severity of the disease. Currently, most suitable and most reliable test is RT-PCR. HRCT is also good. Since we will not talk about it because it's not in our domain, but it can sometimes it can be used for diagnosis also. It third question is a 39 years old woman is suffering from fever and joint pains. Her lab investigation revealed HSCRP raised, IL-6 raised, procalcitonin normal, ferritin raised, but her antibodies done on chemiluminescence were negative. Her PCR was also negative for COVID-19. What should be the next action in this patient? Should we start tocilizumab, that is Actemra, straight away, or antibodies should be repeated after 1 week? Dexamethasone should be started immediately. Other viral diseases should be ruled out. RT-PCR should be repeated weekly for 2 weeks. Yes, what do you say? Yes, other viral diseases should be ruled out. So, third myth number three is acute phase reactions are specific for COVID-19. People say some junior doctors, some patients, they believe that if IL-6 is normal, if CRP is normal, so if IL-6 is raised or CRP is raised, patient has definitely got COVID-19. No, it's not like that. They are not specific for COVID-19. In reality, if these APRs are raised in many infections, inflammations, malignancy, etc. Fourth and last myth, which I'll talk, is HRCRP is the first acute phase reaction to rise in infection. It's very common. People say it's a very good marker and it starts rising immediately. In reality, IL-6 is raised hours before CRP. So if CRP starts rising in 4 to 5 hours, IL-6 has already at a quite higher level in the peak. Why IL-6 is raised before CRP, we will discuss in the subsequent slides. Now coming to the actual acute phase reactants. Acute phase reactants are defined as proteins which increase or decrease by at least 25% during inflammatory state. So the roughly the arbitrary level or the rule of thumb is that at least 25% increase or decrease in a specific protein will qualify this protein as an acute phase reactant. Please note that I've also written increase or decrease. So we will elaborate on what does that mean. Most They are mostly synthesized by liver under the influence of cytokines released from inflamed or damaged tissue. So what happens that when there is an inflammation or damage to the tissue, certain cytokines are released. These cytokines then influence liver, which synthesize the acute phase proteins. Acute phase reactions, we can classify them or we can type them according to three classifications. First is positive, negative. So some APR, mostly these proteins, they are raised during inflammation or infections. So examples are CRP, haptoglobin, all complements, alpha-1 antitrypsin, acid glycoproteins, and procalcitonin, etc. But there are certain negative APRs also. And negative APRs, they increase, they decrease during infection, so that the liver can now take over and make those positive APRs. Examples are albumin, transferrin, retinol binding protein, transferrin. I usually give an example of from armed forces that whenever there is a war imposed on any nation, then some activities they are stopped and others they are enhanced. For example, uh, during any emergency like war, all the training activities are stopped and all the human resources diverted to the war where actual or theater of operations where operations are carried out. So similarly, the bodies then switch their priority from certain proteins like albumin to other proteins like CRP, etc. Then there is another type of classification which is according to the rate of rise. So there are some fast reacting acute phase reactants which start increases as early as 4 hours, attain their maximum 24 to 72 hours, and decline very rapidly. Examples are procalcitonin, CRP, and serum amyloid A. Then there are slow reacting APRs begin to increase 24 to 48 hours, reach to their maximum levels in about 7 to 10 days, return to normal in about 2 weeks. Examples are alpha-1 acid glycoprotein, alpha-1 proteases, and many other. But clinically, these slow reacting are not important because who can wait for 24 to 48 hours? The purpose of telling you about these slow reacting that if some wonders come to you and promote these proteins as an acute phase reactant, please remember that they are slow one, so they are clinically not important. Only fast reacting are important for us. Third type of classification is according to the cytokines involved. But first, let me tell you what is cytokine. Cytokines are actually also proteins or substances which are secreted from the inflamed cells or immune cells, and they in turn act on the liver to secrete the acute phase proteins. So they are classified according, APRs are classified according to the type of cytokine. For example, procalcitonin and CRP, amyloid A, they are potentiated by IL-6 and IL-1 both. So they can be secreted by both IL-6 and IL-1. Then there are type 2 APRs, which include fibrogen, haptoglobin, hemopexin, etc. They are exclusively secreted, stimulated by IL-6 and some other interleukins, but they are not stimulated by IL-1. So academically, you may you may want to know this type of classification also. Now we come to the commonly used There's a long list of APRs, acute phase reactants and cytokines. There are a long list, but they are all not used because of certain reasons. So one is the fastness of the acute phase reaction. We choose only the fast one. Secondly, the ease of analysis. As and when their estimations are available, they come in the market. For example, a few years ago, we were not using IL-6 so frequently as we are using today. So CRP, interleukin 6, procalcitonin, ferritin, and these are the most commonly used APRs these days. Uh, Please remember interleukin 6, I've included in APRs, but truly speaking, technically they are cytokines. IL-6, we will start our discussion with IL-6 because it is a major cytokine. IL-6 is a cytokine that causes induction of various APRs, CRP and procalcitonin. So IL-6 increases much earlier than CRP in infections because first it is secreted from the inflamed cells or immune cells, and then it causes induction of CRP and procalcitonin. So logically also, IL-6 assay should pick this cytokine much earlier than CRP and procalcitonin. IL-6 is a multifunction cytokine. This will be a true eye opener for us, and you will be very excited to know this fact that IL-6 is a wonderful cytokine. It has got multiple functions, what we call pleiotropic effect. My student may remember the pleiotropic effect, pleiotropic functions of HDL, high density lipoprotein. So this is again a pleiotropic protein. Its a major importance is because of its pleiotropic effect. Circulating IL-6 levels are closely linked to the severity of COVID infection. So it has given it has played wonderful role in the present pandemic because it has been shown that uh, IL-6 is not only in one organ system but multi organs. They are involved in their effects are because of IL-6. We will discuss them in subsequent slides. Due to its rapid replication, SARS-CoV-2 virus shows an elevated response of IL-6 induced severe respiratory distress. One of them is respiratory distress. Secondly, so serial measurement of IL-6 level may be important in identifying diseases progression among COVID-19. Immediate initial evaluation of IL-6 level be performed upon hospital admission of COVID-19 patients. Potential benefits to assess worsening clinical features and disease progression in COVID-19. So now, in addition to what I have written on the slide, I want to um, enlighten my colleagues and students that instead of wasting money on some unnecessary markers, we must procure IL-6. And if you are not doing it in your lab, please start doing it because it gives a lot of information in COVID-19 patients. I'm talking of COVID-19 patients, not COVID-19 suspected cases. In COVID-19 patients who are admitted or who are being treated as an OPD patient, you must do serial monitoring, or after initial evaluation, you must do serial monitoring of IL-6. This slide shows the pleiotropic effect. It has got action and inflammation, immunity, reproduction, uh, induction of nerve cell differentiation, hematopoiesis, induction of myeloma cells, and induction of leukemic cell differentiation. So IL-6 is a wonderful protein or cytokine, and it has got multiple functions. You must have heard about the uh, another very important clinical syndrome, which is associated with COVID-19, and it is called cytokine storm syndrome (CSS). So in COVID CSS, many inflammatory cytokines such as IL-1, IL-10, tumor necrosis factor alpha are elevated approximately 200 fold above normative values. But IL-6 demonstrates very high levels, maybe 1000 fold. Several large studies have reported markedly elevated IL-6 levels in 100 to 10,000 picogram per ml. Uh, its normal cutoff is less than 7, and units which are used are picogram per ml. I repeat, its normal level cutoff is picogram is 7, and its unit should be picogram per ml. So don't use some other unit. Don't get confused if picogram per liter is written. Now, all pathologists and clinicians should take this information. However, some authors have questioned there are questioning some researchers have questioned the existence of CSS, and in science, everything goes on. Now, what level of IL-6 is dangerous? This question remains unanswered. There is no consensus about it. Uh, there is no consensus about it, and generally speaking, it is said that level more than 80 picogram per ml is an indication of respiratory failure, or CRP more than 97 is also highly predictive. Now, another importance of IL-6 is the because so it plays very important role in inflammation and infection and immunity, uh, and it may cause cytokine storm syndrome. So, biological agents have been developed, and they are one of them is marketed as Actemera, tocilizumab, which is marketed as Actemera, and uh, it is being used. It was used, and in some settings still used in patients to prevent this CSS or cytokine storm syndrome. But recently, very recently, there are guidelines, there are studies which have advocated not to use any of these biological agents, anti-IL-6 agents, uh, tocilizumab or sariluzumab or siltuximab. These are findings, and also some clinicians have discontinued using Actemera. CRP. CRP is well known, and I have not written a lot about it because you already know it. It is a non-specific KPR secreted from uh, liver. It is a sensitive biomarker for infection, inflammation, and tissue damage. So, if a patient has got rheumatoid arthritis, CRP will be raised. Malignancy, CRP will be raised. So, it is not specific for infection or viral infection. It starts rising very early, 4 to 6 hours, and peaks by 36 to 50 hours. Elevated CRP, a marker of bacterial or viral, it is a marker of both bacterial and viral infection. In COVID-19 patients, CRP more than 41.8 milligram per liter is, uh, uh, is, is, is arbitrarily taken as the level for severity. Once again, I want to draw your attention to the units used. In SI units, we write proteins in milligram per liter, but in traditional units, it is milligram per deciliter. So be careful. Please be careful when you are interpreting reports of CRP, whether it is milligram per deciliter or milligram per liter. If it is milligram per liter, its cutoff is 10 milligram. And if it is in traditional units, it is milligram, it is uh, zero point 0.5 milligram per deciliter. It's very important uh, point of patient safety. Procalcitonin or PCT is a glycoprotein without hormonal activity and the precursor of calcitonin produced by C cells of thyroid in normal conditions. Procalcitonin gene in other tissues is activated, including liver, kidney, adipocyte, pancreas, colon, and brain in infections. PCT is also activated by IL-6 and other cytokines. PCT is not activated by gamma interferon, so it is not produced in viral infection. So this is an important reason. Why it is not in viral infection? Because it is not activated by gamma interferon, which is a cytokine of viral diseases. PCT levels are increased in bacterial infections and therefore can be used to distinguish between bacterial and viral infections. The higher PCT levels in COVID 19 patients may indicate concomitant bacterial infections. Ferritin. Ferritin is also a very commonly used marker these days as an acute phase reaction. Ferritin is a good marker, very good marker of iron deficiency. It has nearly 100% specificity in iron deficiency, which means if ferritin is low, there is only one cause, which is iron deficiency. But there is a big but in it. Ferritin is not a marker uh, for acute phase reaction because why I say I'm against using ferritin as an APR because ferritin is a marker of iron deficiency. And iron deficiency is very common in countries like us. It is rampant. So there may be masking of ferritin rise in a patient with iron deficiency and who develops COVID 19, and you will take ferritin normal. Secondly, there's another very important point. We recently had a patient here in our hospital whose ferritin came out as 37,000. 37,000. And he was admitted for COVID 19. He remained admitted for 1 week or 10 days and got okay and was discharged. He never went on uh, ventilator or any type of support except for oxygen. So, what I mean to say, the severity of the disease was not according to the ferritin level. So, I informed clinician that this patient must be having some other cause of raised ferritin because it is not corresponding to the severity of his COVID 19. So we ultimately advise HFE gene analysis, and I hope we will get the result in a few days. And probably he might be having some underlying hemochromatosis, which has so much high ferritin. So ferritin should not be used as acute phase reaction. And we do we need another fourth APR? Are three not sufficient? So this is a big question for all of us. This is a cantonic representation for my students that IL-6 actually controls the production of CRP and procalcitonin both. I think that will be you will remember it in your memories with this picture. We have an ongoing project also, thanks to the Snipe China, the firm which has provided us the instrument Maglumi also. The title is Comparison of Interleukin 6, Highly Sensitive CRP and Procalcitonin as Early Acute Phase Reactants. The objective is to carry out a chronological comparison of IL-6, HSCRP, and procalcitonin for the early detection of acute phase reaction in various clinical conditions. We are including both COVID-19 and non-COVID-19 patients. So results will be available in a few weeks. I'm sorry I can't share the preliminary data here. My last slide is three markers, namely CRP, IL-6, procalcitonin can be very effectively used for the monitoring of patients of COVID-19. Ferritin should not be used for monitoring. Three are sufficient. None of these markers should be used for the ruling out of COVID-19. That is for the diagnosis. IL-6 is of prime importance in COVID-19 because of its pleiotropic. Out of these, most probably IL-6 is the best one. IL-6 increases much earlier than CRP as it starts induction of CRP. Thank you very much. And if there are any questions, you are most welcome. You can ask me by any means. Thank you.